guys hear me okay? Okay. Welcome. I'm Tiffany Spahn from Diablo Valley Oncology. And on behalf of Diablo Valley Oncology, the American Cancer Society, and the cancer support community, we'd like to welcome you guys to Many Faces of Breast Cancer. This is our annual breast cancer survivor program. We've been doing this, we figured out, I think this is our 8th year. And we love bringing this to the community every year. Our 3 organizations partner well, and you guys always seem to really like it. So it's really nice to have returning faces, and it's nice to have new people here. I just want to do a little housekeeping before we get started, so please turn off all of your cell phones. And there is no break during the program. If you have to use the restroom, feel free to get up and slip out, but we don't have an official break. And the way this program works is we're going to have a series of speakers. We're not going to take any questions during the speakers, but you have cards that came with your packet when you came in. And so write down any questions that come up, and then we're going to have runners coming through, picking up the cards. And then at the end, we're going to have a Q&A session where all the panelists will be up front and able to answer the questions from the audience. And we also have a feedback survey we'd love for you guys to fill out before you leave. We read this very carefully, and we do incorporate your suggestions in future programs. Okay, so first I would like to start and just tell you a little bit about who my panelists are going to be, and then I'll introduce them individually when they're going to come up. But we have a great lineup of amazing women this morning. So we have Barbara Persons, who's a plastic surgeon who specializes in reconstructive techniques for breast cancer. We have Dawn Guglielmino. Did I say it right? I've been working with Dawn for a long time, but I learned today that I didn't really know how to pronounce her name right. But Dawn is a psychotherapist and works with our cancer patients a lot, and she's amazing. And we have Sandy Shaw, who's a physical therapist who also has a lot of expertise in working with breast cancer patients. And then we have a special patient of mine, Kimberly Bice, who's going to share her story with us at the end. So I would like to, before I introduce our partners from the Cancer Support Community American Cancer Society, I just want to show you 2 slides to get this going. So I want to frame this. So I always start my talks with breast cancer statistics because I think it's really useful to put it into context. And I think we all know that breast cancer is the most common cancer in women, except for skin cancer. 1 out of 8 women will develop breast cancer in their lifetime, which is 12%. This year, 2018, will be more than 266,000 women diagnosed with breast cancer. This is a big number, but the good news is when you look at each year, it actually hasn't been going up very much. So it's pretty stable in the amount of women who are diagnosed with breast cancer. The number that has been going up every year, which I always love to talk about, is how many breast cancer survivors are in the United States. And there are 3.5 million right now. So that's you guys. So a little round of applause for that. What is survivorship? So this is a program that's based on talking about issues that are specific to breast cancer survivors. And survivorship is living with, through, and beyond cancer. And officially, there are 3 phases of survivorship. The first phase is acute survivorship, which begins at the time of diagnosis and goes through to the end of the initial cancer treatment. During this phase, cancer treatment is the focus. Then there's the phase called extended survivorship, which begins at the end of the initial cancer treatment and goes through the months after. The effects of cancer and treatment are the focus. And then there's permanent survivorship, and this is the period when years have passed since the cancer treatment ended and recurrence seems less likely. And during this phase, it's the long-term effects of the cancer and the treatments that are the focus. So now I would like to introduce Ann Case. She is a therapist facilitator for the breast cancer groups at the Cancer Support Community.
Hi, everyone. Can you hear me okay? Okay. Hi. I am a therapist facilitator, as Dr. Spahn has told you, at Cancer Support Community, and I also do outreach for our community. And I have had the pleasure of working there, I can't believe this, for 16 years. So, longer than I thought. I see many familiar faces here, and that's really lovely to see. So I know a lot of you are familiar with our programs, but I know some of you probably aren't, so I'm going to tell you about them. We have Our mission at Cancer Support Community is to provide psychosocial support for people with cancer as well as their caregivers and loved ones. All of our services are provided by highly trained therapists and instructors, and they are designed specifically to combat the three major psychological stressors of having cancer, and those are unwanted aloneness, loss of hope, and loss of control. Our programs include counseling, support groups, educational programs, exercise classes, including Pilates and yoga and nutrition classes. Our services are provided free of charge because we want everyone to be able to access them anytime they need them. We are located in Walnut Creek, and we have been serving Northern California cancer community for 28 years now. We offer several programs specific to the breast cancer community. First is our newly diagnosed breast cancer series. This is an amazing series. It is a 16-week series for those just diagnosed, just starting treatment. It's a combination of support group as well as we have oncology experts come in and speak to our groups. And it's a really effective and great way for people to get connected and feel they're not alone and to get started on moving through this process. We also offer a breast cancer networking group, and this group is for anybody diagnosed with breast cancer at any phase or stage of breast cancer for forever. They can come and access this group and be part of it and get group support as well as do information sharing. Additionally, our exercise classes provide a lot of help for those with breast cancer. We have modified exercise for those in treatment, and we focus on how to regain stamina and strength and range of motion post-treatment. Our nutrition classes are great for people who are experiencing breast cancer. They focus on how to build the immune system and how to repair between treatments, and then post-treatment, how to rebuild and move forward in survivorship. We also, as we're talking about survivorship, have a group called the Life After Cancer group, and that is not breast cancer specific. It's for any types of cancer, but it is a great group at that point when you're done with treatment and there's a lot of what do I do now? Where do I go? What's my life like? How do I define myself now? And we have a lot of discussion about that. It's a support group that meets once a month. So that's a sampling of our programs. If you have any questions about Cancer Support Community, I'd be happy to answer them. Thank you.
Thank you, Anne. Now I'd like to introduce Julianne Lee from the American Cancer Society. Julianne is going to talk about the mission, history, and commitment to fighting breast cancer.
Thank you, Dr. Swan. Good morning, everyone. My name is, now before I start, I have to speak on a personal note. I wanted to share that this year, as many of you know, my work in patient advocacy began after my own diagnosis. This year is a major milestone year for me. I am now 30 years post-colon cancer. I'm so pleased to be able to be here to support DVO's event. On a side note, we had our East Bay Gala last weekend, and we honored Dr. Tiffany Swan. Commendation. Thank you to Diablo Valley Oncology for supporting this event. We are so proud to be able to support it. The American Cancer Society is a nationwide community-based voluntary health organization dedicated to eliminating cancer as a major health problem. Our mission is to save lives, celebrate lives, and lead the fight for a world without cancer. And we attack cancer from every angle. We research cancer and its causes to find more answers and better treatments. The American Cancer Society has proudly funded 47 investigators who went on to win the Nobel Prize, considered the highest accolade any scientist can achieve. We are, in fact, the largest funder of cancer research in the country, second only to the federal government. The American Cancer Society also attacks cancer through life-saving policy changes. We fight cancer as much through public policy as we do in the laboratory. Together with our nonprofit, nonpartisan advocacy affiliate, the American Cancer Society Cancer Action Network, also known as ACS-CAN. We have helped enact policies that prevent cancer, such as smoke-free laws. We educate lawmakers on policies that provide access to quality and affordable health care, including life-saving cancer screenings and treatments. And we encourage increased federal investment in cancer research. Finally, the American Cancer Society provides a variety of free patient programs and services, including free rides to and from their medical appointments. I am so pleased to say that this year our #1 top mission priority is patient access to care. It's been said that even the best treatments won't work if a patient can't get there. So in addition to our Road to Recovery program, we have volunteer drivers in Contra Costa. We have now expanded it. We have annual stipend for patients in financial need, up to $500 a year, and that goes towards public transportation reimbursement as well as paratransit vouchers. We now have also launched a new partnership we have with a transportation vendor that partners with Uber and Lyft, and they will serve as a backup for our Road to Recovery drivers. So there's really no reason anyone in this county will not be able to get a ride free of charge. And with that, I will hand it back to Tiffany and enjoy the program. There's a robust agenda, panel of speakers. Thank you so much for joining us.
Thank you, Julianne. Okay, so I'm your first speaker. So I'm introducing myself. So I'm a medical oncologist at Diablo Valley Oncology, and I specialize in the treatment of breast cancer. And when we first started doing this program, I used to try to speak very specifically only to issues that would be pertinent to people who have already completed their cancer treatment, sort of thinking that if you've already gone through your treatment, you didn't really need to hear about new things. And I found that I was wrong because I would get feedback from the audience that they would like to hear about new developments in breast cancer, even if they've already completed their treatment. I think you guys are a group that's very interested in following what's happening in the advances of breast cancer. So that's sort of how I've tailored my talks over the last few years. So today I'm going to cover 3 different topics that are really new this year and very important, but again, may not apply to you directly, but I think just gives you an idea of where the field of breast cancer is going. So the first thing I'm going to talk about is the TAILOR-X trial. This made a huge splash in the news in June of this year, and we'll go through that and why. The breast cancer staging guidelines that's put out by the American Joint Commission on Cancer just changed in January of this year. Try to adjust my mic. And for the first time changed in a way that actually makes a very big difference. And so I'm going to talk to you about why staging is important and what those changes are. And then I'm going to review the new American College of Radiology guidelines for breast cancer screening that just came out a few months ago. So I'm going to start by talking about a trial called TAILOR-X. And last year, for those of you who were here, I talked about and explained the genomic assay for breast cancer that's called Oncotype DX. And Oncotype is a test that we can send on a woman's breast cancer tumor after it's been removed from their body or even just biopsied. And this part of the cancer goes to a company called Genomic Health, where they run a series of genes on the tumor itself. So this is different than genetic testing. The distinction is it's not testing an individual person for mutations in their DNA. This is testing the actual tumor and what is the molecular makeup of the tumor. And so they run 21 genes on the tumor, and based on the results of the presence or absence of these genes, they find a score that they call the recurrence score. And a recurrence score comes back to you as the patient and to the physician on a scale of 0 to 100 and gives us some very important information about the prognosis of this tumor and its response to chemotherapy. So this is a slide of the 21 genes that they are looking at. 5 of them are called reference genes, and then the 16 other genes are important genes in breast cancer proliferation of the cells. And you can see on here we have a few that are familiar to many of you, which is estrogen, progesterone, and HER2 is somewhere on the list too. So those are 3 proteins that we're always looking at and always discussing with our patients when we're talking about treatment. And then there's a lot of other genes in here that are very important as well for breast cancer. The score is broken up. I'm going to advance a couple slides. Well, I'll start here. The graph is broken up into 3 categories. There's low risk, intermediate risk, and high risk. So patients who have a score of 0 to 17 are considered low risk, and intermediate risk is 18 to 30, and anything above 31 is high risk, and I'll let you know what that means. So who's eligible for an Oncotype DX recurrent score? So one thing that happened in the press in June is, which does often happen with the press, is they said that this would change the treatments for 70% of women with breast cancer. And that was kind of misleading, because what it does is it changes the potential treatment for 70% of women who were eligible for the Oncotype DX test. And not all women diagnosed with breast cancer are eligible for this test. It just would not apply to them. So the women that we typically use this test for are women who have early stage breast cancer, usually stage 1 or stage 2, with negative lymph nodes. So the lymph nodes under their arm, when they were sampled, did not have any cancer in them. Tumors have to be at least 5 millimeters or half a centimeter, and they have to express the estrogen receptor, or progesterone actually as well. Either of the hormone receptors need to be positive. And then this other protein called HER2 has to be negative, because HER2 cancers are treated very differently. So this doesn't cover everybody who's diagnosed with breast cancer, but it does cover a large population. And the idea of the Oncotype is to help us decide, of these women who are going to be treated with anti-estrogen treatment, all of them, because they have estrogen-positive breast cancer, which of these women will also benefit from chemotherapy. So it's very important, because we know chemotherapy is important for some breast cancers, but not needed for all of them. And we don't want to give women potentially toxic treatments if they don't need it. So here is a sample of the Oncotype report as it used to be. And it was a 3-page report, and it would show you the score. You could see the 10 up there, so this is a low-risk score. And there's a graph that shows you where the score would map out to as far as percent risk of recurrence within 10 years of breast cancer. So that's called prognostic information. So I could say to this patient, your score is 10, which means your risk of the cancer coming back elsewhere in your body in the next 10 years is 7% if you take your anti-estrogen or hormonal treatment. And the second page in the middle shows you what is the chemotherapy effect. See if I can zero in on this here. So down here is kind of a nice picture that if the score is in the intermediate or low risk, there's not much benefit to chemotherapy, maybe a little bit more in intermediate risk, but if you have a high risk score, chemotherapy is very, very important. And then on the third page, they retest actually the estrogen, progesterone, and HER2 on the tumor. So this assay actually has been out since the early 2000s or so, or mid-2000s. And so I'm actually reviewing a little bit of old stuff for you before I tell you what came out in June. So people who have a lower recurrence score have a lower likelihood of recurrence of their cancer. They have a greater magnitude of tamoxifen benefit. So tamoxifen, as many of you know, is one of the estrogen blockers that we use. And we extrapolate this, that they also have a benefit to aromatase inhibitors, which are also estrogen blockers. And there have been further tests later showing that that benefit applies to both tamoxifen and the aromatase inhibitors. And if women have lower recurrence score, they have minimal, if any, chemotherapy benefit. If they have a high recurrence score, they have a greater likelihood of recurrence of the cancer within the next 10 years. They have a lower magnitude of benefit for tamoxifen, and they have clear chemotherapy benefits. So this is a nice graph. NSABP B20 was one of the studies they used to validate the Oncotype DX assay. And what you can see is in women who, they have 2 lines here, women who received chemotherapy with their tamoxifen and women who received tamoxifen alone. All of these women had low risk scores, so their scores were all under 18. There's absolutely no difference when you look at those curves between receiving chemotherapy or not if you have a low risk score. So chemotherapy not needed. In the high-risk score, you could see the curves separate there pretty significantly. So those who received chemotherapy in addition to tamoxifen had a better outcome at 10 years than women who did not receive chemotherapy with their tamoxifen. And this is the intermediate risk. So this is our gray zone. Again, generally, it looks like there's not a significant difference between chemo and no chemo, but there is more of a separation between the two lines than we saw with the low risk score. So the concern is, what do we do with these intermediate risk patients? We don't really know. Should they get chemo? Should they not? And so they designed the Taylor X trial, which was designed to look at women whose score was in the intermediate risk and try to find where there's a cutoff where we can say they do or do not need chemotherapy. So this trial that came out and was presented and published in June was trying to get rid of the intermediate risk group of the Oncotype DX assay. And they did that. They succeeded. So this is how they did the study. They took over 10,000 women who were eligible for Oncotype DX assay. So they had hormone-positive breast cancer, HER2 negative, lymph node negative, and they ran their Oncotype score. If they had a low-risk score, they went on to their hormonal therapy as usual. If they had a high-risk score, they had chemotherapy and hormonal therapy as usual. But if they had an intermediate risk score, they were randomized to either receive chemotherapy or not. And what's important to note in this study is they actually changed the score groupings. So low-risk score was lower, so it was 0 to 10. High-risk score was 26 and higher, and so the intermediate risk score, so if you recall before it was between 18 to 30, is now 11 to 25. So everything got shifted down. And the reason that they did this is they did not want to miss any patients who might have been at the upper end of the low-risk score that may have gotten a chemotherapy benefit. They didn't want to undertreat anyone by putting them on this trial, so everything got shifted down. And what they found is that in women who have a recurrent score of 11 to 25, they did not have a significant improvement in their outcomes by receiving chemotherapy. So this slide was the big news, is that you could now safely tell the patients in the intermediate risk group that they did not need chemotherapy. They were very similar to low-risk patients. So this was what was all over the news, and this was a big deal, and we were waiting for this result for a very long time. They looked, and this is a great slide, I think. So if you look at the top line, which is the light green, those are women whose recurrence score is 0 to 10, so kind of the new low risk. And those women, by receiving just hormonal therapy alone, only have a 3% chance of their cancer returning within 10 years. That's a 97% cure rate. That's amazing. And in the second line, which is arms B and C, they put together the intermediate risk, so women who received chemo and didn't, and if you recall, they were the same. Their risk of recurrence in 10 years is 5%, so they have a 95% cure rate, which is also amazing. And then the high-risk score still does have some risk, even after chemotherapy, so their cure rate is in the high 80s with a high-risk recurrence score. Then, and so this is where they started. So this is the general report, is if you have a score of 0 to 25, you don't need chemo, and if you're 26 or higher, you do. So that's the general guideline. However, they looked at it a little bit more closely, and they decided to separate patients out by age. And so they looked within the study at women who were over the age of 50 and under the age of 50 to see if there was a difference, if age plays a difference. And so in women who are over the age of 50, that holds. They basically don't receive any chemotherapy benefit until their score is 26 or higher. However, in women who have breast cancer under the age of 50, they actually found that in women who have a score of 21 to 25, they are receiving a benefit of chemotherapy of about 6.5%. Anything less than that, so 20 and lower, there's not a significant, no benefit or one or so percent. So now the way we read the Oncotype DX is if you're over 50, 26 or higher, you need chemo, otherwise you don't. But if you're under 50, we use 21 as the cutoff. So if your score is 21 or higher, you would be recommended to have chemotherapy. And so now we don't have an intermediate risk anymore. We have a line, and of course, I've had a few patients who are 26 or 25, and that's a discussion if you're right at that line. But now we have more of a cutoff than we used to, which is great and very important. Okay, I'm going to shift gears here, and I want to talk about breast cancer staging. So what is staging and why is it important? So staging is a classification that allows the physicians and other healthcare providers to really stratify patients and allows us to have a common language in talking about our patients. And so I can talk to someone in England or in China or somewhere else in the country and say, my patient has stage 2 breast cancer, and they know exactly what I'm talking about. It's common language and it's universal. It allows standardization of data collection, so when patients are participating in clinical trials, we know how to group them in trials based on stage. And guidelines are based on stage because stage tells us what the prognosis is. So a higher stage cancer has a higher risk, lower stage cancer has lower risk. And so in many clinical trials, they're studying certain stages of cancer. And so in general, staging cancer, not just breast, but all cancers, provides higher care. So the AJCC 7th edition staging for breast cancer was what we were using up until December. And this is what we call anatomic staging. So the staging is based on the size of the tumor, which is called a T stage, whether or not the lymph nodes are involved, which is the N stage, and then whether or not they're metastasis or spread outside of the breast and lymph nodes, which is the M stage. So we call it TNM staging. And staging was based specifically on that, just where it is in the patient's body. So what happened in January is, for the first time ever, the staging committee decided to incorporate the biology of the tumor into the staging, which of course they should do. I mean, we've been treating cancer based on biology and not just stage for years, but staging did not reflect that up until now. So now, when we look at staging our patients, we do look at how big the tumor is. We look at whether it's in the lymph nodes or not. We look at whether it's spread elsewhere, but we also look at what is the estrogen receptor, what is the progesterone receptor, what is the HER2 protein, those 3 important proteins, and what is the grade of the tumor. So how aggressive does the tumor look under the microscope on a scale of 1 to 3? So now we've incorporated all of this into the staging. So the problem is, where it was very easy to memorize that, we can't memorize it anymore. So this is just a little bit of it. There's actually now 140 or more permutations of staging. So all of us who work in breast cancer have a nice app on our phone, and we just plug it in, and it's great. Here's another. These are just all the stage 3As you could have. I mean, it's mind-boggling. What's really nice about this, though, is I can go back to my patients, and even patients who have been diagnosed prior to January, and say, you were a stage 2A when you first were diagnosed, but now, because of your favorable estrogen and progesterone, you're actually a 1B. And so some patients' stage has moved down because of the biology of their tumor. But there are very few stages that actually move up, meaning get a little bit worse because of biology. It's usually a downshift of staging, which is really nice. I met a patient the other day who had been told and had for years that she had stage 3A breast cancer, and because of her favorable panel with the estrogen, progesterone, and the HER2, she was downstage to a 2A, and that just completely, made her day and her year. She was very happy to hear that. Another thing that's important that's been added to the new staging is the Oncotype DX. So we've just talked about that. And because if you recall the score, that anyone who has a recurrence score of less than 11 has such a high cure rate of 97%, they've now incorporated Oncotype into the staging so that anyone whose score is less than 11, assuming they have negative lymph nodes, is automatically a stage 1A. So their prognosis is so good that Oncotype score trumps a lot of other things. And so that's very important. It's the first time that a genomic assay has been incorporated into breast cancer staging. So I think that's important and affects all of you, actually. And the last thing I want to talk about is the American College of Radiology put out their new breast cancer screening guidelines. They did not change their guidelines for the average risk woman, but they did change their guidelines for higher than average risk women. So the first thing the distinction to make is these are women who have not had breast cancer, just women who are at risk for breast cancer. And then I'll also touch on women who've already had breast cancer and what are we doing for their screening as well. So early detection decreases breast cancer mortality by more than 40% in women who are over the age of 40. The The American College of Radiology recommends annual mammograms beginning at age 40 for women who are at average risk for breast cancer. This has not changed. We now have the updated recommendations for women at higher than average risk. So what is higher than average risk? So we know that women who carry a genetic predisposition to breast cancer have a higher risk of developing breast cancer. This only represents 5 to 10% of breast cancer. It's not a very large population, but for those women, their risk of breast cancer is higher. BRCA1 and BRCA2 are the most commonly found mutations and the ones you hear about all the time. But there are other genes, and so now when we used to do genetic testing, those were the only 2 genes tested. Now when I send my patient for genetic testing, some of them get 80 genes tested. So we've come such a long way in being able to identify high-risk genes in our patients. And some of the other ones that are more prominent are TP53, CHEK2, P10, CDH1, STK11, PALB2, and ATM. So when a woman has a genetic mutation, they meet with a genetic counselor and have very comprehensive discussions about what their risks are for breast cancer and other cancer risks as well. Outside of that, women who have a strong family history of breast cancer, particularly first-degree relatives or relatives who were diagnosed at a younger age, are known to have a higher risk of breast cancer. Women who underwent radiation therapy to their chest, usually this would be for lymphoma at a young age, and particularly if they were treated under the age of 30, they can have a lifetime, or they can have a risk of breast cancer up to 20% just by their mid-40s. So they're at extremely high risk of breast cancer. And in general, for those women, they recommend starting their screening at age 25 or 8 years after their radiation, whichever is later. So those women do and have been getting more intensive screening for their breast cancer. And now African American women are also included in the higher than average risk. It turns out they have a similar incidence of breast cancer, but are often diagnosed at later stages, and so their outcomes are not always as favorable. Dense breasts, and this is a buzzword, has been for a while, and now I think those of you who get mammograms have these little paragraphs at the bottom of the mammogram that says you have very dense breasts and your mammogram may not be that great, but they don't really tell you what to do about it. And dense breasts are rated by radiologists. That there's a heterogeneously dense breasts, there's extremely dense breasts, and then there's some who just have lower density, and then there are women who have no density in their breast. And dense breast means there's less fat, basically. The more fatty a breast is, the easier it is for a radiologist to read the mammograms. And 43 to 46% of women over the age of 40 in this country are thought to have dense breasts. So that's a lot of us. And what they're looking at now is the new 3D mammograms, which I'm going to talk about, are better at looking through dense breasts. So they're going to relook those numbers because now that we have better screening for dense breasts, we may not be as worried about breast density as we have been. And in general, women who are younger have higher breast density. There are a couple of precancerous lesions that are called, there's atypical lobular hyperplasia, lobular carcinoma in situ, and atypical ductal hyperplasia. These are not cancers, but they are precancers, so they are markers. When a woman has a biopsy that shows one of these, we know that they are at increased risk of breast cancer and could be up to 20% lifetime risk. And so these are considered higher risk and are included in this category. So for women who have a breast cancer history, so this is relevant to a lot of you, the risk of developing cancer in the other breast is 0.5 to 1% per year during the first 10 years after diagnosis. But the good news is, because many women with breast cancer undergo treatment, the treatment reduces the risk of developing that other cancer by 50%. Both chemotherapy and anti-estrogen or hormonal therapy reduce that risk. Women who have been diagnosed with breast cancer under the age of 50 have a 20% lifetime risk of a new breast cancer, and their risk is also cut in half with the treatment for the breast cancer that they've had. So let's talk about mammograms. Mammograms are still the gold standard for breast cancer screening, but in the last few years, we now have 3D mammograms. And what we were using before were digital mammograms, which were two-dimensional. Now we have 3D mammograms, and I was going to try to put a movie in, but I'm not that sophisticated. But I do have a picture to show you. And so a 3D mammogram is a little movie through your breast. It's like a little CAT scan. And when we look at them in our tumor boards, it's phenomenal how much more sensitive they are at picking up small cancers. And so this has really changed how we screen breast cancer, and we're lucky to live in this community where we have 3D mammograms, and we have for a few years now. So they have a better detection rate of breast cancer. They have lower false positives, so fewer women are called back to have biopsies for things that are not cancer. Specifically, they are finding improvements in the younger women, less than 50, and women who have higher breast density, and also for the genetic mutations, as we talked about, and their untested first-degree relatives. And they're actually recommending that they begin their screening now at age 30, and also for women who have a lifetime risk of 20% or higher, which we had talked about. So this is a few different slices of a 3D mammogram, and you can see that if you look at the first three, you don't see very much, but when you move into that fourth picture, and if you can imagine this being, if you're scrolling through this and all of a sudden that little density comes up, you see the cancer that you might not have seen if you were looking at one of the other slices. Then we have breast MRI, and MRIs are very, very sensitive for looking at for breast cancer, as well as many other things in the body. Breast MRI does not use radiation, it uses a magnet, and an MRI of the breast requires an injection of a contrast called gadolinium. And MRIs are very sensitive. They do have a higher false positive rate than mammograms. MRIs use blood flow, so they're actually looking at blood flow in the breast, and a lot of different things can increase blood flow. So cancer can do it, but so can fibrocystic breasts and just some general, I don't know, different areas where there's more dense tissue, glandular tissue. There's a lot of things that can increase blood flow. So there are more false positives with breast MRIs. But this new guideline for the first time has incorporated breast MRI into screening more than it ever has. So prior to the new guidelines, we were using breast MRIs for women who have the BRCA1 and 2 mutations or other gene mutations. Also for women who have a known BRCA mutation in the family. For the relatives who have been untested, they qualified for a breast MRI as well. And for the mutation carriers, start those at age 25. We talked about the women who received radiation at a young age. They get breast MRIs once a year as well. And anyone who has a calculated risk of greater than 20% in their lifetime. And it's important to note, MRIs do not replace mammograms. They're in addition to, so we tend to stagger them. So if my patient's getting a yearly mammogram in January, then in July they get their MRIs. So every 6 months they're having a very nice look at their breasts. So here's a picture of a breast MRI, and it's a very clear picture through the breast. You can see blood vessels, which are all the little lines, and then you see a large tumor. If I can, right there. And then this may be another tumor or what we call an intramammary lymph node or something else that's abnormal in the breast. So this is a pretty clear picture. So this is a breast MRI. So the new recommendations, so what the new ACR guidelines now include, is anyone who's had a personal history of breast cancer under the age of 50 qualifies for yearly screening MRI. So this is a lot of people. So all of a sudden I'm ordering a lot more MRIs than I was before. And also anyone who had a personal history of breast cancer at any age who's considered to have dense breasts on mammogram now qualifies to have an MRI once a year. Also, the women I talked about earlier who have those precancerous lesions, LCIS or lobular carcinoma in situ particularly, but also consideration for atypical ductal and atypical lobular hyperplasia. It's not recommended for women who have not had breast cancer and have dense breasts. So it's not for everybody with dense breasts. So all that 43 to 46% of us don't all get mammograms. And then there's ultrasound, and ultrasound is a tool that is very useful in breast cancer, particularly when we're diagnosing a breast cancer. So if a woman has their first mammogram that looks abnormal and they come back for additional imaging, and they will often have an ultrasound. Ultrasounds are very useful for looking at the lymph nodes under the arm. Ultrasounds are not great for screening, but we have been using them for the past several years, particularly for women who have dense breasts. And it does increase the sensitivity a little bit, not a lot, but there are more false positives with breast ultrasounds. So now with the new 3D mammograms, ultrasounds do not help us. So if you're having a 3D mammogram with dense breasts, you don't need an ultrasound in addition. And certainly if you're having a breast MRI, you don't need an ultrasound. So 3D mammos and MRIs appear to be trumping the ultrasound for screening. In women who can't have an MRI for some reason, they have a pacemaker or something, or live in a community where they can't get 3D mammograms, then ultrasound should be considered for those higher risk women. And that's my last slide. Okay, thank you for your attention. And if you have any questions for me, please write them on your card, and we will address them later during the question and answer session. And now I would like to introduce Barbara Persons. I've been working with Barbara for many, many years. She's wonderful. She's a reconstructive surgeon who specializes in breast cancer.
There you are. Perfect. Yep. I'm shorter than you are by a good bit. You see why I call Tiffany all the time when I want to know if my patients can or can't have estrogen, what they need to do. She knows it all. I want to thank Diablo Valley Oncology for having me here, as well as cancer support community, and the American Cancer Association. I see lots of friends, patients, and family out here, and my patients become family over the few years that I have the opportunity to take care of you. I'm a board-certified plastic surgeon, also trained in general surgery fully, and I am just so passionate about taking care of breast cancer patients. My mother had breast cancer, my 2 grandmothers had breast cancer, and I also have a personal journey of my own that led me to be a patient and have some 20 surgeries or so, and the opportunity to see you folks and then to work with you. It's just the most amazing thing ever. This morning, a patient of mine, Anna, texted me these pictures saying that she wanted to be here but couldn't because she was busy. She had unilateral breast cancer on one side, had a mastectomy and radiation, and then found out she had a rare syndrome, had to have the other breast removed, and had her ovaries removed and the eggs banked, and then since got married and had these 2 babies. So there's so much life and so much family to going through all this together. Yeah, she's amazing. And then this is also a woman that I went to see, Little Vinny. I don't know if any of you have had nipple tattoos as part of your reconstruction, but she did, and he was supposedly the best person ever, and she brought like 20 women down to a beautiful hotel in San Diego, and we all learned from him how they do nipple tattoos. So needless to say, I defer to Little Vinny now for the tattoos. And my talk's going to be a little more humorous. In plastic surgery, we're pretty right brain. So pregnancy, breastfeeding, menopause, cancer, yes, does all these things. I have 3 children of my own, so I know well. And we just, there is some humor to it because our breasts, as women, we have such a relationship with our breasts. They're like, what are these things starting to happen when I'm 13 to, having babies, to sensation, to possibly breast cancer. So when I see you all in my office, and I'm referred, you're referred to me by Tiffany or Dr. Lee or or the other wonderful people in the area, or also my colleagues, Dr. Vivian Ting and Michelle Place and Dr. Kerman. It is the start of a beautiful relationship. Usually when you end up in my office, what you're hearing in your head is cancer, 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 and sit down, start talking about whether you'll keep your breast or lose them, what losing them means, what the possibilities are for reconstruction. There are so many things, and I'll talk to you about what many of you have already gone through. And as Tiffany said, I feel like often at this stage, having gone through it, you know as much as we do in many ways, but there are several new things. So we'll talk about those. And I had a little video that I couldn't make play because I'm not tech savvy enough, but it's 2 minutes about my own journey through having a bunch of surgeries, and I'm 30 years accident free. So and then with my family history, perhaps I'll be going through breast cancer with some of you in the future. Reconstruction, as I just talked about, is a huge journey, and I get patients like this from outside of our area or from other health systems, and you know, the little take home of that is that there's such a spectrum of what we see, and this woman was told by another health system that she was too fat to have reconstruction. So I also see all of us as advocates for what our standard of care. There is, you know, basically everyone should be offered their first stage reconstruction with their surgery. That doesn't mean they have to do it, but they should be offered first stage reconstruction or a very nice closure of their chest as their first stage. And it's very popular right now to consider direct implant, and that still is something that is done less commonly because it's not as reliable. And so the type of treatment, what kind of surgery, reconstruction, when is the best time, is a team approach. So I like to spend a lot of time. Want you to have my cell phones, as everybody knows. I always run late, but I see it as a very personal relationship, and I know Dr. Svan does as well. We're so lucky. The possibilities for reconstruction and why it's such a relationship is that the stages of going through reconstruction, and why I put this first picture up, is that between having your breast and having your new breasts is this middle ground where you have an expander. It looks funny. It feels hard. You may be going through radiation. You may even gasp, lose your implants, and then at the end, the world is your oyster. I mean, in terms of plastic surgery, I'm on board to get you to the kind of result that you want and deserve. I just have a few pictures of the possibilities of bilateral reconstruction now and what they can look like. While they're not your natural breasts, with some surgery and tenacity, we can get there. And I'm hopeful that one day, being up here, we'll be able to say we don't have to do surgery for breast cancer ever again. I will be so happy when that day comes, because while we can do great reconstructions, they're not your natural breast. This all turned out whiter than the actual patients are, with nipple sparing and not nipple sparing, with tissue expanders. And tissue expanders reconstructions these days are so good. I went through 9 years of surgery training to learn microsurgery and flap surgery to do really great flap reconstructions. And there are times for those when people are going to have radiation, for example, and when people don't like the idea of implants. But now with breast implants, and I should have brought some of the new implants, we're on 4th generation silicone gel breast implants, and they do get better. They get better every year. They have gone from being hard rocks to only saline to silicone again to textured to smooth, and they're great. And then just as far as the sharing, I tell people that I have a set of implants because I would have 0 breast tissue without them, and I feel like they're very safe. It's still a device, and so it won't last forever, but they are a useful option for reconstruction. And there are some really great microsurgeons in our area, and I'm microsurgery trained, but I don't do as many DIEP or free flap reconstructions as some other people like Dr. Kerman, which is a very valid option to go through. I think patients don't often, may not realize that that's a long run. That's like 12 hours of surgery and often 3 or 4 surgeries. But in the patient who needs it, it's a good option as well. This is speaking to the nipple tattoos. This is a breast reconstruction with implants and nipple tattoos, and And I think that when I came here 10 years ago, Dr. Svan may know of someone else who did, but I had been trained to not ever make an incision right across the breast because it was a definite, you have breast cancer, could not stand naked and say, I just had a lift. So when I came here, I distinctly tortured my general surgery colleagues who are so good and had them do incisions under the breast or down the breast and would not let that incision go straight across the breast if I could help it anymore. So this is why, is I think we can get more natural looking breasts. They still feel like implants, and then they also implants that have been placed under the muscle, as these are, still move a little bit when you do pull-ups or work out your arms. So it's popular to do implants above the muscle now as well, but I notice that they get somewhat hard when people do that. So it's a trade-off, and that's where it's a big discussion, and just super fun. Here are a few just other reconstructions. I think the newest best thing in the last several years that has come along is fat grafting in breast reconstruction. We routinely perform mastectomies when they're needed, do a first stage reconstruction with a tissue expander, which I'll show you in a second, and then change that out for implants in 6 weeks to 3 months. After that, a couple of sessions of fat grafting can be used to really improve the contour to get breasts that can look as good as they did before someone had mastectomies. The fat is taken from wherever you want to lose it, so that's the bonus. So and typically it's covered by insurance, so you can have fat grafting. Yeah, I want to lose it from wherever, and then it is placed in the breast in a couple of sessions, procedures, and can rebuild the tissue. Also, people who have really thin skin or have had radiation. The fat grafting can be used even before the implant reconstruction to make the tissue softer and more like natural tissue. There had been a concern in the past that this could potentiate breast cancer recurrence, and that's not been seen to be true in our literature. Also, the question was, is it harder to read mammograms? And in our tumor board, the thought is that our radiologists can do an excellent job of differentiating your fat that's been transplanted from anything abnormal. So I support that. And then I also noticed that with fat grafting, it can be used to the breast, and it can also really help that when people lose some volume elsewhere, like in their face from chemotherapy, and help them get their groove back. So I'll sneak some fat out of the fat grafting to the breast and help people have a little bit in their face. This just shows a tissue expander and an implant, and basically the tissue expander is placed along with a mesh. For the last number of years, we've been using a donor mesh. There are several different brands of that, and then now there's a new mesh called Galatea. That's a synthetic mesh, and I think with all the synthetic meshes, they really need to be used for several years before we know whether it's a perfect idea or not. Oncoplastic surgery is something that has been around for a while, but it gives the opportunity for us to do perhaps fewer mastectomies and also to make the breasts look better as we're reconstructing them. The blood supply to the breast is fantastic, and we can use our knowledge of that. When I started my breast fellowship, my boss said, I want you to get the history of the blood supply to the breast back to the 1600s. And after having some stuff translated by Salman, it was, it's real blood supply. So my general surgery colleagues can do a lot of just beautiful lumpectomies where they can keep the breast looking natural. Sometimes you don't ever need to see me, which is unfortunate for me, but the less surgery you have, the better. And with our colleagues, Dr. Eigelberger and Dr. Lee and several other people. They just do beautiful work. With that, I have a little slide mix-up, but if we can, you can, which is get your mammograms done. And now we know mammogram in certain groups. Thank you for the education from Dr. Svan about who should get them, when we should get them, and then the little pitch for breast self-exams is really important as well. Every patient that I see, every patient that I see in the office who I touch their breasts, I say, do you do breast self-exam? Do you do it every month? Please, do that, because 50% of women find their own breast cancers, as we all know. Thank you very much for having me, and then I can't wait for the panel, because I hope you have lots of questions, and it's just really fun to treat breast cancer and to have it be gone. Just let's get it out of our world. Thank you.
Thank you, Barbara. That was fantastic. And so if you have questions for Dr. Persons, please write them down, and we will go through them, as she said, during the panel. Now I'd like to introduce Sandy Schall. Sandy is a physical therapist who works with a lot of breast cancer patients. And I first heard about Sandy through one of my patients who is also a colleague and a friend of mine. And she just raved and raved and raved about Sandy, and I had not yet met Sandy at that point. And that is the best endorsement that you can get, is actually talking to someone who's worked with someone who's made a huge difference in her life. So we're very happy to have Sandy here.
Hi, I'm Sandy. I own Health Pro Physical Therapy. We have offices in Walnut Creek and Concord, and I've been a therapist for over 30 years. And I do see a fair amount of breast cancer patients in various stages, and we do a lot of different work with them, and I'll go through some of the things that we do for physical therapy. There's a lot of issues that can occur after breast cancer. A lot of you are familiar with some of these issues. When you have surgery, it can affect how well you use your arm, how well you can breathe, how well you can do your activities of your daily living, your tasks at home. So basically, pain and stiffness can interfere with what you're doing after you've had surgery. There's also swelling issues, lymphedema issues, and other types of issues with neuropathies and types of pain and scar tissue that can develop as well. Some of the main things we see most of all, pain can occur in the shoulder, the chest, the back, the neck, and the arm. We also see scar tissue formation, adhesions, fibrosis around the breast area, as well as in the shoulder area and the scapular area, neck and back. One particular type of syndrome is the axillary web syndrome, a cording, which is a specific type of scar tissue that occurs in the axillary area in the armpit. We see a lot of restricted range of motion of the shoulder, the neck, and the spine in relation to interference with the ability to move, fibrotic tissues, capsulitis, that types of thing that develop. We see a lot of weakness and fatigue from lack of use. Some immobility after surgery can cause the shoulder to freeze up, so we see a lot of that as well. Tension headaches from muscular issues and just overall stress and fatigue. Neuropathies, skin sensitivities, other nerve syndromes, especially post-mastectomy pain syndrome, which is a type of neuropathic pain. So we deal with those as well, and also lymphedema, which can be fairly common after surgery when the lymphatic system is involved. There are things that can be done even before breast cancer surgeries, the prehabilitation stage, basically. A therapist can assess the baseline measurements, range of motion, circumference measurements, and strength before surgery. We can identify anything that may be going on in the body beforehand that may be either related or non-related to the cancer, such as postural dysfunctions, other types of pains that might be pre-existing, any types of weakness that might be there ahead of time. We can do education in lymphedema, management and risk reduction, and we can also establish an exercise program ahead of time going into surgery so that the patient is aware of what they can do immediately right afterwards as soon as it's safe for them to begin. The surgical treatments, physical therapy treatments that we can do after breast cancer surgery, there are various types of manual therapy techniques that can be done to the tissues, to the joints, to the muscles, and scar tissue. And I'll go over more of those in a slide coming up. Lymphedema treatments, and it can include lymphatic drainage, edema massage, help with learning how to do compression bandaging, evaluation for compression garments, and instruction in exercises and self-care. Postural training to assess any postural changes that may have occurred after surgery due to muscle imbalances and weakness, with postural specific exercises, ergonomic assessments for optimizing your ability to minimize your risk and your injury following surgery, and again, more education. There's exercises that can be instructed throughout all phases, prior, during, and after surgery. It's been proven to minimize or eliminate the side effects of breast cancer treatment, and individualized programs can be provided to you by a physical therapist once it's been approved by your doctor. Pain management can be affected by manual therapies, which we've already discussed some of, moist heat. Sometimes low-level laser therapy can be used, as well as the stretching and the exercise. The type of manual therapy that can be done for tissues is the scar tissue mobilization techniques, which can work on the scar of the actual incision areas. It can work on myofascial tissues, which are the connective tissue that holds your muscles and tendons and bones all together. It's kind of like a web that holds all that together. You can get restrictions in that as well. We can work on edema and lymphedema massage techniques to help reduce swelling and fluid retention in the extremity, and it can be the arm as well as other areas of the body as well. Desensitization techniques, which will help to reduce neuropathic pain, sensitivity based on injuries to nerve tissues in the skin and around the arm, and also nerve gliding and mobilization techniques for the nerve, because the nerve tissues will shorten as well with immobilization. So we too try to help lengthening with nerve gliding techniques, and also the soft tissue work will help to remove some of the sensitivities of the nerve endings in the skin. General soft tissue mobilization and massage techniques can be just generally beneficial for just blood flow, a sense of well-being, a release of endorphins, and relaxing muscle tension. Passive range of motion and joint mobilization techniques can be done on the shoulder to help regain range of motion from restrictions from immobilization and scar tissue. We also do work on the neck and the spine and the ribs as well, so that we can enhance your movement in those areas as well. Muscle energy techniques are types of strain, counter strain exercises, or isometric types of exercises. It helps to break up muscle restrictions and helps to improve movement. Some of the exercises that we recommend after breast cancer surgeries, it's important to do it to get the arm moving, again, because we tend to lose mobility. It helps to decrease the side effects of your surgery and help you get back to your usual activities quickly. If you've had radiation therapy after surgery, it's even more important because you get a lot more restrictions when radiation is involved as well. It's also very important to talk with your doctor before starting any exercises to make sure that you're ready for this, that there's no contraindications, that all the things that are important, such as sutures, drains, that type of thing, have been cleared before you start therapy. The physical therapist would be the ideal person to see to make sure they can minimize risk, make sure you're moving forward properly, and make sure your plan is tailored for you. So basically, it makes your arm stronger, and you can start your range of motion fairly quickly after surgery once the precautions are cleared. Examples of exercises that can be done in the week after surgery, if your doctor and your therapist approve. Using your arm with light tasks, activities of daily living, combing your hair, brushing your teeth, doing light activities, reaching, doing movement to minimize the immobilization of the arm that can cause restriction in the shoulder. Lying down and raising your arm above your head, having it in an elevated position on pillows throughout the day a few times, up to maybe 45 minutes. Doing activities such as hand pumping, wrist pumping, elbow pumping, just to get the muscles moving so that the fluid doesn't accumulate in the arm and it can minimize the occurrence of lymphedema. You want to practice deep breathing exercises as well so that your rib cage doesn't start locking up as well. So taking deep breaths in, using your diaphragm, expanding your ribs and your lungs to help keep your chest area from restricting as well. And also trying to avoid laying on the affected arm after surgery so that you're not further impinging that area. There are some things to keep in mind after breast surgery, things to be aware of, that you will feel tightness in your chest and your arm. There will be feelings of restriction and discomfort. This is normal and it will decrease over time. Many women have the burning or the tingling, numbness, soreness in the arm, the neck, the back, the chest, and those are in response to trauma to the nerves and the muscles and the tissues during the surgery process. So that's basically keep your doctor informed of those things, make sure that they're going in the right direction, that you're not developing any complications. Also letting your therapist know if you're working with one so that they can modify the treatment to make sure that you're not causing additional harm by doing something too aggressive. It may be helpful to do the prescribed exercises in a warm shower. It might help to warm up the muscles, increase the blood flow, so that might help a little bit to keep things looser, make it more comfortable for you to perform your exercises. Making sure you wear comfortable, loose clothing when you're doing exercises so that you're not causing further restriction with tight clothing. Do the prescribed exercises slowly until you feel a gentle stretch. You don't want to be doing stretches that cause pain. You want to just progress to the point where you feel a stretch and just kind of hang out in that position until it starts to loosen up. And you can push a little further once it starts to give a little bit, but try not to cause pain when you're doing your stretches. If you have trouble with the exercises, make sure you talk to your therapist or your doctor to make sure that there's nothing incorrect about what's being done. Make sure your technique is correct and that you're not causing further harm. And make sure you take deep breathing in and out while you're exercising so that you're not holding your breath. Sometimes when we're in pain, we tend to hold our breath and then you get lightheaded and you're not getting oxygen to the muscles that you're trying to stretch. After you have progressed and start regaining your range of motion, you can start adding in exercises based on what your therapist feels is necessary for you. Different types of exercises, such as wand exercises, as you see in the first picture, using a stick to help. The good arm will help the bad arm to move further. So there's types of exercises where you can be pushing with a stick to kind of move your shoulder in ways that it doesn't want to move on its own. You can do exercises to the shoulder blades, to the shoulders, and to the trunk to help to increase strength in those areas. And then just general upper body strengthening exercises, light weights, gentle resistance exercises, adding in aerobic exercises to increase blood flow and to just overall improve your cardiovascular status and get back to your usual routine. Lymphedema exercises, as indicated, if it's necessary for you to do those on an ongoing basis because you do develop lymphedema, those will be helpful for you to do in an ongoing, continuously for, until it doesn't seem to be much of an issue anymore. But sometimes lymphedema can hang around for a long time, so if not permanent in some cases. So, all right. that's pretty much what I do with my cancer patients. And if you have any questions, I'll be happy to answer when we're all finished. Thank you.
Thank you so much, Sandy. And if you have questions for Sandy, we'll address those later. So as many of you know, when you go through a cancer treatment journey, there are, of course, a lot of physical things that happen and difficulties, but it's often the emotional and psychological component that's just as important, if not more so, for a woman or man going through a cancer journey. And at Diablo Valley Oncology, Dawn Guglielmino has been our go-to person to help us with psychosocial support for our patients for many, many years, and she's absolutely amazing. And so we have Dawn, who is a marriage and family therapist, who will be talking to you today.
Thank you, Tiffany. Still hard for me to believe that I'm actually standing in front of people talking. It's not my specialty. Good morning. I came to dealing with cancer through a journey of my own. So I am a cancer survivor, breast cancer survivor, and have quite a bit of experience, both from the personal level as well as the professional level. And so today we've heard a lot about the new treatments, the new procedures, the different therapies, all about cancer. And now I'm going to spend a few minutes sort of shifting from the cognitive to the feeling state and what ends up happening to us, our thoughts, our experiences, our relationships with the people as we are hearing that we have cancer, we are dealing with it, and we're learning to move beyond the cancer. When clients come in, they want relief from the emotional stress of everything that's just happened. They may have some financial problems or concerns. They may not feel safe moving forward. They may have worries about, is it going to come back? When is it going to come back? How am I going to deal with it? Am I going to notice it? They may have some specific needs related to the treatment of the cancer, or the medications, the side effects, and all of that. They may have concerns about the people in their lives that they have been taking care of. How are they going to move forward? Any one of these, or the combination of these, can lead the breast cancer patient to suffer from anxiety and depression. And this is something that we actually can really help with. We can really move you to a place where it's not a constant fight, but instead it's a process. So who are the faces of breast cancer? Very often they have this ripple effect, and the people who are the faces are all of you in this room. It's the people that we interact with. It's those that are in our immediate family, it's our friends, it's our community members. And I like to spend time focusing on this because cancer isn't all about being cured with medicine or surgery or both or all or whatever. Oftentimes, in order for us to really get to that place where we have the healing, we need to experience and talk about what's happening all around us. And that's what the therapist can help the client with. we live with social connection, emotional support, participation in normal life activities, and we need to be engaged in life. And we want to move away from that place where we're stuck. And life is all about going to treatment and cancer, and there's nothing else going on. And the goal when we get together is, how can we get you back there? How can we get you to that place? How can we help those that are helping you to get you back to that place? The breast cancer stops us in our tracks. Along with the physical side effects of illness, there's the potential for the psychological. I deal a lot with anxiety. The good news about anxiety is it makes you feel so incredibly miserable, seriously, so incredibly miserable, that you're actually willing to come in and do something about it. And the other good news about anxiety is it is one of the quickest things that we can turn around. Oftentimes what's going on is we deny that we're feeling what we're feeling, and we move along as if it's not there, until it gets to a place, really, seriously, where it's paralyzing. It gets in the way of your actually walking through the doors to get your treatment, because you're already finding yourself getting sick, and you haven't even had your treatment yet, or other kinds of things. So anxiety is one of those things that we deal a lot with. Interestingly enough, our natural inclination is to run from anxiety and to deny that it's there. What I would like to offer you is that the thing that really helps anxiety to diminish is to go in the direction of what's causing the anxiety, to really talk about it, to share experiences with it, to really befriend it. I know, it's not a friend, but we're really going to say to really embrace it, to understand it and what its message is trying to tell you. When the anxiety goes on and it's not dealt with, it often takes us to a place of depression and a feeling of hopelessness and lack of control and just generalized, I don't want to be engaged. It creates a sense of isolation. And so we want to really catch it and deal with it before it really starts crippling us. So I'm way off my list here, but that's okay. I think that some of the techniques that we use can seem really simple, and you can question, really, why does it work? How does it work? Some of the things that I bring into my practice and what I really teach some of my clients is that thing called mindfulness, that a buzzword that's used by everybody, and I think oftentimes not really understood. It gets really overly complicated, and they bring in meditation with it, and all kinds of things happen. But mindfulness is a practice of really paying attention to ordinary things with a lens of a small child. It is a way in which we can get out of those thoughts which start to trip us up, the what ifs, the catastrophizing, all of that other kind of stuff. And it can bring us back to that moment where we, despite all that's happening, can still enjoy that day because maybe the sun is shining. Maybe, the birds are singing a song that really sounds very differently. And it allows you to feel the peace of being connected in this social milieu that we call life. Another tool that I use is cognitive behavioral therapy. Again, this has lots of different permutations to it. But basically, a lot of people come in with this roommate that's moved into their head that has nothing good to say. I mean, nothing good to say. It tells you, how lopsided you look. It tells you how fat you are. It tells you how incompetent you are. I mean, it really has some pretty bad messages that it wants you to pay attention to. And you know what? When we are sitting there and feeling miserable and not getting up and not getting around and all of that kind of stuff, we have a lot of time to listen to that roommate. So we talk a lot about how to notice the roommate, but not listen to all the messages, or how to counter the messages that might be coming in, how to identify where those messages are getting distorted. And that's really what the cognitive behavioral piece of therapy is all about.
Again, it's not any stroke of brilliance, but it is something that can bring relief when it feels as if there's nothing that you have control over. I know a lot of cancer sounds like it's negative and it's bad and all of that, and I want to talk about the positives that come out of cancer. It's hard to believe, right? There's actually a lot of literature that's come out that's talked about the stress of dealing with breast cancer not being all bad. It can promote resilience. It can promote a greater sense of peacefulness and purpose in life. And it actually can enhance your self-esteem because you're learning to pay attention to yourself in a way different way. All of these positive traits can actually happen simultaneously with the distress that comes along with cancer. So it's not an either or, but it's an all-encompassing. There's some positive, there's some negative. And part of really getting together and meeting with someone is enhancing and shining a light on those ways in which you are being changed, but not in a negative way, in a positive way, where you now have a mission and you get to share that because of your experience. So in conclusion, I would like to say, let's remember that the many phases of breast cancer are not just the patients, but they're also their families, their friends, their caregivers. We are social beings, and we don't heal in isolation. Everyone in this room is a very important part of the healing process. Allow yourself to really just take that message in. Thank you.
Thank you, Dawn. You see why we all love her. So over the many years that I've been doing this, I've come to grips with the fact that no patient ever wants to meet me. And I don't take that personally, of course. But when I meet a new breast cancer patient, it's a powerful moment because these women come in and they have very recently been told that they have the big C, right? They have cancer. There is a lot of fear and anxiety in that first appointment. And a lot of the fear, of course, has to do with, am I going to survive? What is this cancer going to do to me? But a lot of the fear is also, I'm not strong enough and I'm not going to be able to do this. Women are facing surgery and radiation and hormone blockade for sometimes 5 to 10 years, and often chemotherapy that's intense for several months. And everybody feels like they can't do it, but you know what? They all do. And everybody finds this inner strength during that journey. And it's so satisfying for me as their physician to watch that journey and come through it with them. And so that is one of the positive things of breast cancer, and it's women finding their strength. So I'm inspired by my patient's strength every day. So Kim is a wonderful patient that you're going to hear about. I've known her for many years. She actually had her treatment elsewhere on the East Coast, which she's going to tell you about, and then transferred her care to me when she was living this area. And the first time I met her, I was so moved by her story. And so now you all get to hear it too.
Thank you. Let me just adjust the microphone. Is that okay? Okay. Good morning. I feel honored to be here this morning. I have been a breast cancer survivor for over 18 years. I've learned over the years that every cancer survivor has a unique story, and I'd like to spend a few minutes this morning sharing my story with you. I had just turned 34. Cancer was not on my radar at all. I didn't have any cancer history in my family, not breast cancer, no cancer. I learned later on that most women who get breast cancer don't have it in their family. I've had so many people say, oh, I don't need a mammogram, I don't need to do a self-breast exam because I don't have it in my family. But most women don't have it in their family. I think a lot of people don't know that. I'd had a breast exam 9 months earlier, and nothing was suspicious. Everything turned out fine. I'm a rule follower, so I was doing my monthly breast exams, and in the shower. One day I felt 2 separate lumps in my left breast. And of course I was in denial. I was 34, no history in my family. You know, breasts are lumpy anyway, so it could just be something different. I did go call my family practice doctor and went to visit him. He examined my breast and he ordered a mammogram. I almost canceled my mammogram appointment because, again, I was 34 and there's no cancer in my family at all. How likely is that, right? I did find out later that many women under 40 actually do get breast cancer. Of course, it's not as common, but it happens. The mammogram, this doctor was very suspicious when he read the mammogram and said, yes, you need to get a biopsy. At the time I was living in the Midwest. After the mammogram, I decided to go to a well-known hospital in Minnesota for the biopsy and for additional tests for staging purposes. After that, I found out that my cancer had metastasized outside of my breast. It was very aggressive. I had so much nodal involvement that was not just under my arm or supraclav. It actually had already spread to my cervical nodes. I actually one day was kind of playing around and I could feel these bumps, very obvious bumps in my neck. And that's when I found out later what that was. That was cancer in my cervical nodes. They said there was a 20% chance that I would be alive in 5 years. They were not going to try to cure me. I'm kind of a stubborn person. But let me go back for 1 second, because this is important to me. They told me that if I did survive this very poor, grim prognosis, if I did live, which they didn't think I would, they said that I would probably never have children. That is when I broke down and cried. It was more devastating for me to find out that I would never have children than to find out that I'd most likely die before I turned 40. It took me a few days to process everything. I would be in denial, I'd be angry, I'd be sad, and I did start bargaining with God. My cancer was very aggressive, and I had to make some decisions quickly. As I mentioned, I'm a very stubborn person, and I thought, if I'm gonna go, I will go kicking and screaming. I realized I needed to be my own advocate. I didn't want to go home and die like I was told would happen. I thought, what have I got to lose, right? I decided to get a second opinion. Someone recommended a physician in New York at Memorial Sloan Kettering Cancer Center. I went there and saw a medical oncologist named Larry Norton for a second opinion. Dr. Norton told me that my prognosis was poor, but he would treat me aggressively by using a chemotherapy protocol that was being studied in a clinical trial there. Dr. Norton was the first person since I felt that lump in my breast who gave me any hope. Hope is priceless. I flew home to have my chemotherapy treatments, which I started right away. Someone had recommended to me that I should get my wig before I lost my hair, which I found was excellent advice. It was nice to get it out of the way. Well, I still was feeling well. And someone to show, like, this is what my hair looks like. So I remember meeting with my doctor before my first chemotherapy infusion. The first chemotherapy drug I took was adriamycin, the red devil, because it's red. He told me, I just signed disclosures and said, if the adriamycin does touch your skin, there's a chance you'll need plastic surgery. And then I realized, and this would be coursing through my veins. That was a bit overwhelming. On the first day of my treatment, I brought music along with me to listen to. I chose disco because I just had such a difficult time feeling sad when I was listening to disco. I can't tell you how many times that I listened to Dancing Queen that year. I can still hear it in the back of my head. Then at night, I practiced visual guided meditation. I visualized the chemicals, going into my body that day, and then just destroying my cancer cells, just blowing them up, destroying them. And then in the morning, they all washed out. So that was how I thought of it and dealt with it. And I know chemotherapy is really difficult for most people, but I really practiced that at night. It felt peace, and I felt, I'm fighting this. It's a good feeling to feel like you're fighting it. I knew I had to get through this. I had to do what I could take to take care of my whole self. I only spent time with positive people, and no doom and gloom. I tried to stay as positive as I could and laugh as much as I could, which was very difficult at times. I had some very dark days. I remember one day I was in my bedroom on the second floor, feeling terrible and looking outside, and everybody's riding their bikes, walking their dogs, and you realize, like, everybody else doesn't know what you're going. They're just going on with their life. I was a Seinfeld fan, and I watched as many reruns as Seinfeld as possible. It always made me laugh. I had to stop trying to please everyone. People would say, do you want to go out for lunch? And I would, want to say yes or whatever. And then someone told me something, and I started doing it. I would say to people, I would love to go out for lunch or dinner with you, but that day I really need to see how I'm feeling. So I think a lot of times women especially, you want to say yes and, and try to please everyone. You just really have to take care of yourself. I was in a fight for my life. I had one shot at this. Not only did I need to be aggressive with my treatments, but I had to take care of myself in another way. I also have a new motto then. It was no regrets. I had good days and bad days, both physically and emotionally. Losing my hair was difficult, and not just because I'm being vain. Just a few weeks earlier, I looked completely normal. I felt amazing. I had this life going on, and all of a sudden, it's like splat into a brick wall when you hear your diagnosis. Within 2 weeks, I had lost my hair. I looked sick. I felt sick. And it's so hard to think. 2 weeks earlier, everything was just fine, or I thought it was. I think it's hard to look in the mirror when you're bald because, for me anyway, I thought I really look sick. I mean, I look sick. A lot of times I wore a baseball cap and didn't wear my wig because I was just too lazy. And so when people would see me and they could see, I didn't have any hair, it's just difficult. I don't know what else to say. One day I was in the shower though. I lost my hair, my eyelashes, quite a few, my eyebrows. But one day I was in the shower and I realized that I still had hair on my legs. I was shaving my legs, and I remember thinking, yes, God does have some sense of humor, right? After my chemotherapy was over, and waiting until my body would be healthy again, I went ahead with my mastectomy. I went back to New York City to Memorial Sloan Kettering Cancer Center the Monday before Thanksgiving that year. My breast surgeon, Alexandra Hirt, was not only very competent, she was also one of the nicest physicians I've ever met. On that cold, dark day in New York City, she stopped and talked to me in pre-op and gave me peace about my surgery that day. My surgery went well. Thank you, Dr. Hirt. After recovering from my surgery, I flew back to the Midwest. After about a month, when I was healed from my surgery, I went down to Barnes Jewish Hospital in St. Louis and met my radiation oncologist. Her name is Dr. Marie Taylor. My case was complex than most because of my staging. The PET scan showed affected nodes, as I mentioned, including cervical nodes. After my chemotherapy, though, we couldn't feel the lymph nodes anymore. So we at least knew the chemotherapy had been working, at least some, because I no longer could feel those. No longer could I feel the breast lumps. Dr. Taylor still wanted to radiate the area to leave no stone unturned. Again, my motto was, no regrets. Over the weeks, I got to know Dr. Taylor. I shared with her that before my diagnosis, I was planning to go back to school and do something in the healthcare field. So talking to her about my interests and things, she told me about a profession of medical dosimetry. Medical dosimetrists are members of the radiation treatment team. They're people that you probably will never see because they don't actually interact with the patient, but they work behind the scenes with your physician. And I will get back to that later. On my first day of radiation treatment, I remember going into the treatment room and changing into my gown. They had me lay on the treatment table and set me up in the correct treatment position. After the first radiation therapist left the room, I noticed the other two were walking away as well, out the door. I said, "Will you stay in here when I have my treatment?" "No," they said, and they left. It was kind of scary to me being treated with something that I couldn't see. At least my chemotherapy, I could see it. I don't know. I was fortunate enough to have a radiation therapist with a great sense of humor. Radiation therapists are the ones that put you on the treatment table, they leave the room, and they deliver the radiation beam from outside. There was one therapist that I will always remember. His name was Vito. On the first day, when he came to get me out of the waiting room, he had this lush hair, this dark, long, lush hair, and I'm bald, so I was just hair envy. I was just gazing at his hair. And I said, "How long will it be until my hair is as long as yours?" Vito had a great sense of humor. Every day he came in, and you have to lay very, very, very still when you get your radiation. And he would come in, he'd set me up with the other therapist. He'd make me laugh so hard every day. They had to say, "Okay, you have to stop laughing and hold very still." So I was really blessed. Overall, my radiation treatments went well. My skin did get redness, and I used Aquaphor to put on that area. Although, other than that, I was a little tired. The weeks went by until I had my final treatment. I went out to my car and sat in the parking lot after my last treatment. I didn't know what to do. For months, my whole life revolved around my cancer and my treatment. I had been actively fighting every day to stay alive. I realized that I had to reassess my life and decide what my new normal would be. One of the first things I did, I went to the shelter and got a dog. Her name is Sophie. I'm not sure which one of us needed the other more, me or Sophie. My doctors told me that I had a high chance of reoccurrence. I knew, though, that I didn't want to just wait for my cancer to come back. I needed to proceed as if I would survive. I reconnected with friends, took care of myself, and found different ways to volunteer in my community. When I say that I needed to proceed as if I would survive, that doesn't mean that I wasn't terrified of a recurrence. Every ache or headache caused me to worry for quite a few years. Eventually, I researched the profession that Dr. Taylor told me about, medical dosimetry. So many people had helped me during my cancer treatment, and I decided I wanted to give back. I started looking into different dosimetry programs around the country. There aren't very many. And in 2003, I was thrilled to be accepted into the program, the University of Texas MD Anderson Cancer Center. They have a great program there, and I feel blessed to have gotten my education there. What is a medical dosimetrist, you ask? Oh, that was my first slide. Dang it! Dang it, I missed my first slide. Okay. I like that she has a Band-Aid on her cheek, right? You know, as women, we're strong, we're resilient, and we persevere. So that's why I like Fight Like a Girl. A medical dosimetrist is a member of the radiation oncology team who works closely with the radiation oncologist, a medical physicist, and the radiation therapist. The medical dosimetrist creates a unique radiation treatment plan for each patient. Every patient has their own unique treatment plan. There's not one size fits all. Technology is so amazing and so advanced now that the treatments are more conformal than ever before, and patients have fewer side effects than ever before. So it's wonderful. Even though I'm in remission, I follow up every year with my oncologist. It is important to have a good relationship with your oncologist. I happen to love mine. Thank you, Dr. Swan. Some of you may have seen on the right side is a linear accelerator. Some of you may have already seen that. The patient is laying on the table. The radiation therapists are setting the patient up. And as I mentioned, they'll leave the room when they treat the patient. Like I said, if you've had radiation already, you know that they make sure you're in the exact position every day. It's so precise. And on the top left is a physician with a medical dosimetrist, and they are looking at the treatment planning computer and planning that unique treatment for you or for the patient. I have some tips for you. Be kind to yourself. Be your own advocate. Remember who you were before your diagnosis and dream of who you will be. Embrace hope and learn to love disco. I have one last thing I want to share with you today. 7 years after my diagnosis and very grim prognosis, I gave birth to a beautiful baby girl. She was born 15 weeks early at 25 weeks gestation. She weighed 1 pound, 11 ounces. She spent 3 months in the ICU. She's a fighter like her mama. My daughter's name is Courtney. She's 11 and she's in 6th grade, and she's here today. Thank you.